Okay, so today we're going to continue talking about essentially what the effectiveness of healthcare expenditures appears to be empirically. And so last time we sort of finished off talking about this this randomized experiment that the Rand Corporation ran back in like the late 70s, early 80s, was some time ago now, where they basically randomly assigned insurance plans of differing generosity levels to people and measured both their total expenditures on healthcare, or the total expenditures on healthcare for them, and their health. And essentially what the key result was that people who were on more generous plans did in fact consume more healthcare, I guess almost about 50%, because it was sort of a 25 to 30% reduction relative to those who were on the very generous plans. But their health didn't seem to be any different. So it didn't seem as if increases on the margin in healthcare expenditures are actually having any impact on health, at least so far as they can measure it. So that's sort of one piece of the healthcare expenditure puzzle. But the other piece is going to be whether or not people actually have healthcare coverage at all, or health insurance coverage at all. So you can sort of think of total healthcare expenditures as being determined both by the total amount of insurance coverage in the population. So if you cover fewer people, then presumably you'll be spending less because people won't be able to afford healthcare since they have no insurance. And then also it's going to be determined by the generosity of the health insurance that you're providing. So the generosity sort of component was what Rand was getting after, but they didn't actually test what happens to healthcare expenditures and what happens to healthcare if you simply don't cover somebody at all. Right? There was no insurance control group in the Rand study. And as far as I know, there haven't really been very many randomized control trials that look at what happens when you have no healthcare insurance at all. There's actually a very recent one being conducted in Oregon using Medicaid coverage. So there, it's not that you're randomly assigning people to have no healthcare insurance, because there's no way you can sort of take healthcare or health insurance away from somebody who already has it. But what they have is basically a list of people who want to get onto Medicaid, and they have a limited number of slots, and they're actually randomly assigning whether or not. So given that there's a shortage of slots that are available, they're randomly assigning slots into Medicaid to people and then looking at what happens. But there's also a bunch of quasi-experimental papers that are using observational data and looking at sort of like Medicaid or other sort of healthcare coverage expansions and measuring what happens to people's health. And it does seem that when you expand healthcare coverage, so that when you give people health insurance, there does seem to be an effect on their health. So there's a paper, it's not in the readings, but it basically uses cross-province differences in the Canadian National Health Insurance Program to estimate the effect of health coverage on infant health. So the idea here is that, as some or many of you may know, Canada has a national health insurance program that basically covers everybody, but that wasn't always the case. So it was actually rolled out back in the 1960s and 70s. And instead of just introducing it in all of the provinces at the same time, they actually introduced it in different provinces at different times. So some of them got in early and then some of them got in later. And so because you're introducing it in different provinces at different times, that basically gives rise to like a differences in differences type design, where you look at the provinces that get it early and compare how health outcomes for people who are gaining coverage under this health insurance program, see how those change relative to health outcomes for people who are in provinces that aren't getting it, so basically control provinces. And what they find is that infant mortality and the incidence of low birth weight infants seems to decline by about 5 to 10%. And perhaps more significantly, these improvements are really concentrated among single mothers, who are the group who it turns out were most likely to benefit from the National Health Insurance Program. So there are a lot of people who already had some sort of health insurance before this, right? Because if you're like employed in a good job or something, probably the benefits include health insurance benefits. So for those people, you wouldn't really think that rolling out this National Health Insurance Program is necessarily going to have much of an effect. But for single mothers who didn't have health insurance coverage before, they should presumably see some impact if health insurance is actually helping, in this case, their children, the infants. And that does appear to be what's happening. There's also another study that looks at California and basically looks at what the reverse, or sort of looks at the opposite, which is a case where people used to have health insurance and then you're taking it away from them. So Medicaid is, so as I said like earlier, you think of sort of like health insurance for poor people, in particular, either poor children or poor people who have children. And it's funded essentially by like the federal government, but then it's actually implemented by the states. And so Medicaid in California is what's known as Medi-Cal. And it used to be that Medi-Cal would cover adults. This was back up until about 1983. And then they rolled that back, so they decided they were no longer going to cover poor adults. But there were still some poor adults who qualified for Medi-Cal. So pre-1983 in California, you can think like all poor adults are going to be covered. And then post-1983 in California, only poor adults who were either blind, disabled, or had dependent children were going to still be covered. So now you can think of like the treated group, so to speak, as being poor adults who didn't fit into one of these three categories here. So they were going to lose their health insurance coverage in 1983. And then the control group are these poor adults who do fit into one of these categories, blind, disabled, or with dependent children. And so they're going to continue to have their health insurance coverage even after 1983. And so then they basically do a diff and diff type design and see what happens to those people who are now losing their health insurance coverage in 1983. And they do find a significant decline in health perception and in diastolic blood pressure. So decline in blood pressure, I think, means like it gets worse. So normally blood pressure going down is good. I think by decline here, I mean it's getting worse. What's going on? So that's, you're surveying people about like their self-reported health. So like I can come to you and say, on a scale of 1 to 7, where 1 is say extremely unhealthy and 7 is extremely healthy, where do you rate yourself? So not a great measure. Yeah, I would agree. Right, so it's very subjective. It's not like a clinical measure. You're not measuring somebody's like cholesterol level or their blood pressure or something like that.
Do they know that they're actually studying the effects of terminating the...
I don't think so, because I think this is like, I don't think they were running their own survey for this. I think it was probably sort of a general like survey that's probably run by like the California State Department of Health or something like that, where they're just surveying people from the general population. But no, it's definitely, it's not a great measure. And you could if you realize that was the purpose of the study. So I don't, like in this case, I think because it was run by, because I don't think it was run by the study author herself, I don't think it was sort of strategic bias. But certainly, I mean, the fact that you just lost health insurance coverage would probably color your answer, even if you hadn't realized a significant decline in your actual physical health yet. And so actually the reason why I am very, I wouldn't say confident, but the reason why I think there's a very high chance that would happen is that that's in fact exactly what has been observed in this Medicaid Oregon study that I mentioned. So at some point I guess I'll probably actually work its way into these slides. But so what they again, what they're doing is they're in Oregon, they're like randomly assigning whether or not people can get on. So all these people signed up for Medicaid and they're sort of randomly admitting some of them and not admitting others, and then comparing how the people they admit onto the program do in terms of health compared to the other people. And so what they find is, I think sort of the two main findings are, so first of all, once you get admitted to the program, you are more likely to start going to the doctor and so forth, so that's not at all a big surprise, right? The second thing is that for most of their clinical measurements, I think they find little or no effect, but for self-reported health, they do find a significant effect. So like self-reported health status does increase significantly for those who are admitted into Medicaid versus those who aren't. But if you look at the timing, so they're actually like following people over a 1 or 2 year period, and if you look at the timing of how quickly those self-reported health measures improve, it basically happens like in the first month or something. So in particular, it happens way before most of the increase in actual like doctor's visits and hospital visits and so forth occur. And so it seems like what's happening is people are like, oh, now I'm covered with health insurance. I really feel like a lot better. I know that if I get sick, I can get treated. And maybe you had some sort of chronic condition. You're like, now I know I can get this treated. Your general stress level may just be much lower now. And so that's not to say it's not to say that improvement shouldn't have any value assigned to it, because you are actually sort of improving how people feel about themselves. And at the end of the day, like when we write down a utility function, what do we actually mean by that? It's basically like are people happy or not? So I wouldn't say that the measure is completely worthless, but at the same time, it doesn't really seem like it's measuring sort of what you might think initially, which would be like actual physical health according to clinical measures of blood pressure and cholesterol and HDL and LDL and all that kind of stuff. So there's definitely reason to be skeptical here. So some other papers, again not in the readings, but that sort of speak to this question are one. So there's one by Allman, Jane Greenstone that looks at the desegregation of hospitals in the Deep South and finds that it seems to have caused a dramatic drop in infant mortality. So again, this is going from like really bad healthcare to some okay kind of healthcare. This is not, you don't want to think of this as sort of being like the marginal healthcare improvement that we would or the marginal improvement that we would expect to see from improving healthcare today. But what they do is they examine the impact of rapid desegregation of hospitals in Mississippi on black infant mortality rates. It's not even really quite like a difference in difference design in the sense that they don't have a very clear control group, although I guess you could think of it as kind of being the whites. But the figure I think is pretty convincing. So what you have here is like the Civil Rights Act gets passed around 1965, I think it was in 1965, and that outlaws segregation in a lot of public spaces, including hospitals. And so before it was like the black people in Mississippi had to go to the black hospital. Post 1965, the federal government steps in and says, no, you have to allow them to go to the hospital where the white people go. I don't even know. I mean, maybe the black hospital was basically like not actually a hospital. But so what you can see here, so what they're plotting is just the infant mortality rate for blacks, which as you can see is like something like about 6 times higher than the infant mortality rate for whites in Mississippi in the pre-1965 period. And there is a trend downwards in infant mortality for both groups. So even the whites, over time, as you would expect or hope, the infant mortality rate seems to be trending downwards. But post 1965 for the blacks, there's this huge and very quick drop in the infant mortality rate. In just about 3 years, I guess it drops by about 67%. So you could tell stories about omitted variables that might be causing this drop simultaneous with the Civil Rights Act passing, but I think it would be pretty far-fetched. It seems most likely that the desegregation itself is actually causing it. Eric?
Is this number of deaths per 100,000?
Yeah, so this is number of posting new deaths. So I guess they're plotting, so it looks like they're plotting like just the total number, but it should be pretty, like I don't think the number of births or number of pregnancies is changing dramatically over this time period. So even if you divide through by like number of pregnancies, I think it would still look pretty similar, or number of births, yeah. So on the extensive margin, increasing health insurance does seem to, or increasing health insurance coverage for uncovered people does seem to have an impact on health, but increases in expenditures on the intensive margin, in contrast, seem to have relatively low effect. So for those of you who aren't sort of familiar with language of extensive and intensive margin, what we're referring to there is the idea of chalk. So if you have some variable, let's say x, that can take on values that are greater than or equal to 0, then basically the extensive margin refers to the probability that x is greater than 0, and then the intensive margin, or to change on the extensive margin would look at what happens when x is greater than 0, and then the intensive margin is looking at essentially, so if you want to write it down in terms of expected values, it would be the conditional expectation of x given that x is greater than 0, but what that means is essentially changes in x if x is greater than 0. So in practice, I think that I think these concepts are sort of easier to demonstrate with examples than they are in terms of the formal definition. So one of the sort of quintessential examples from labor economics of the extensive versus intensive margin deals with somebody's labor supply. So you can basically either choose to work or not work, and then conditional on working, you can choose your number of hours. So the choice to work at all is basically what we refer to as a choice on the extensive margin, and then the number of hours that you work conditional on choosing to work is what we refer to as the intensive margin. One of my colleagues was he recently proposed to his girlfriend, and so before he proposed, like he was going to Hawaii, and at one point he kind of said like, oh yeah, I'm thinking of proposing, but I'm not quite sure yet. And I wasn't certain whether, so I asked him later, like, oh, are you going to propose when you go to Hawaii? He's like, yeah, I'm still not quite, I'm not really quite sure. And so I was like, well, is the uncertainty on the extensive or intensive margin? And he was like, oh yeah, no, it's just on the intensive margin. And I was like, okay, that's good, because if we're on the extensive margin, then I don't know that this is something you should just like immediately do or sort of flip a coin on whether or not you're going to do in Hawaii. And I think I mentioned that to my wife, and she was like, what the hell does that mean? But my colleague understood immediately. He was like, oh yeah, no, the answer is on the intensive margin. So like in that context, when I said extensive versus intensive margin, the question was like, so on the extensive margin, the question is like, are you going to propose to her at all, right? And conditional on deciding, yes, in fact, you are going to propose to her, then on the intensive margin, the question becomes, well, when are you going to propose to her? Like, are you going to do it now, or are you going to wait a few months or something like that? And so he was saying, yeah, no, I definitely am going to propose to her. I'm just not sure if like I'm going to do it on this trip to Hawaii, or maybe like I'll wait a couple months or something like that. And he ended up like doing it on the trip. But when I told that to my wife, she was like, how does that make any sense? Why would somebody phrase the question that way? And like this just shows that economists are really bizarre. And I was like, well, look, but he understood me perfectly, and immediately like gave the correct response. But then now the problem is like now she's like trying to throw in extensive versus intensive margin, all sorts of contexts in which it doesn't really make any sense. So it turns out there's some cost for that. But that's another example of like where you could use the two terms. And then so in this context, in the health insurance context, again, what you want to think of is the excess margin is whether you have any insurance at all, and then the intensive margin is like, well, conditional on having insurance, how much are you going to, like, how generous is the insurance? So like, if you have any insurance at all, you're going to get all of the sort of basic procedures that you should get to get any, to be treated in a way that would be sort of viewed as like remotely clinically appropriate. But then when you talk about like the intensive margin, it's sort of like, well, you're going to get some elective procedures, or you're going to get like diagnostic tests that, probably aren't really necessary, but maybe could have some benefit, and so we'll give them to you. Like, are you going to get like the super fancy surgeon, or just like the ordinary surgeon, or whatever? So when they talk about like gold-plated healthcare plans or something like that, then you're sort of talking about a change that's on the intensive margin there. So these changes on the intensive margin seem to not have all that much relationship with health outcomes. So, for example, there's a paper here by Winberg and co-authors that looks at differences in Medicare expenditures across different regions of the country, and it turns out that there's more than a twofold difference in Medicare expenditures. So this is a little bit surprising in the sense that the terms of Medicare do not differ by region of the country. So like everybody faces sort of the same terms of Medicare. It's not that it's not sort of giving a different coverage package to people in Minnesota than it is people in Florida or people in California. But despite that fact, there's actually a very large variation in average Medicare expenditures per enrollee for these different regions. And when you look at so some regions are like high spending per enrollee, some regions are low spending per enrollee. And if you look at what this spending correlates with, so I'll say what in a second what it correlates with, but actually I think sort of what's more interesting and more disturbing is what it doesn't correlate with. So the higher spending regions do not seem to be providing more effective care. So when we say effective care in like a healthcare context, what we mean basically is whether or not patients are receiving care that is that's basically consistent with like the best known clinical practices. So in some sense, you would think that like giving effective care is kind of trivial because it's not even really about spending more per se. I mean, it could be in some cases, but really what it's about is like, given that you have some particular set of symptoms or some particular disease, is your doctor prescribing like the treatment that, according to the latest clinical research, is the most effective treatment for that disease. And it turns out that just because Medicare happens to be spending twice as much in a region doesn't mean that doctors are any more likely to prescribe the things that, according to the latest research, should be the best treatments. So it's not generating more effective care. The additional spending is generating more effective care. It's also not generating more elective surgery, so surgery that sort of could be considered optional, which is maybe a little bit surprising. I mean, you'd think that like if you're spending more in a given region, probably it might be just because people are sort of getting treatments that you would think of as being maybe useful but not really necessary, so elective. And the fact that it's not correlated with more elective surgery is probably on net a good thing in the sense that we may be doing too much surgery at the margin anyway. It's also not correlated with better health outcomes. So again, that's kind of like a disappointing fact. You would hope that if you're spending more, you're getting better health outcomes, but that doesn't seem to be the case. That being said, you could make a case for like some sort of selection bias. Like maybe some regions just have really unhealthy old people, other regions have very healthy old people, and so Medicare is spending a lot of money to try to offset the unhealthiness of the people in the high spending region. But if you then look at what is correlated with the additional spending, or basically where the additional spending is coming from, it seems to accrue from a pretty broad variety of factors, but particularly specialist visits. So higher spending goes into more physician visits, so the areas they're spending more, people are going to the doctor more often. More specialist consultations, so that gets expensive because the specialists tend to be expensive, and you can always you can get a lot of specialist consultations once you have something wrong with you. I'll just say that. So, and the reason is like usually, so it's like you go to your doctor and they're like, well, you obviously have these symptoms, we're not quite sure what's wrong. You can think of all sorts of like different possible things that could be wrong, and given those possibilities, then you could think of like all sorts of specialists who would be relevant to those different possibilities. And so it's very easy to go to like half a dozen different specialists and get their take, and nobody really knows, and so they'll all tell you something. Hopefully, in the best case scenario, they'll kind of agree, and that suggests that they might actually figure out what's wrong with you. But in the worst case scenario, you just get a bunch of different opinions that are all conflicting. It turns out also the consultations are particularly concentrated for chronic disease and concentrated during like the last 6 months of life. So this is sort of where the incremental Medicare dollar appears to go. So which is to say that if one region is spending like $10,000 per enrollee, and then the second region is spending $20,000 per enrollee, where is that additional $10,000 of spending going in region 2 versus region 1? It seems to be going into these types of consultations. And the differences in spending that we're talking about here are quite large. So Miami is a high spending area, and a 65-year-old there is going to be expected to have lifetime spending that's $50,000 higher than a 65-year-old in Minneapolis, which is one of the lower spending areas. So a lot of this is going into end-of-life spending, but the value of that is very unclear, I would say. So if you sort of look at the basic facts, it turns out that the local supply of specialists and acute care hospitals explain about 40% of the variation in the intensity of end-of-life spending. But what the direction of causality is there is not entirely clear. So there's two possibilities, right? So what we're seeing here is that the supply of doctors or supply of these specialists is correlated with the intensity of end-of-life spending. So if you want to tell what we call a supply side story, basically the story would be like, well, you've got all these specialists there, they need to earn money, otherwise they're not going to be able to pay off their loans. So the way they earn money is by arranging all these consultations for patients, even if the consultations don't really do very much. So that would be a story in which basically this is all just waste because it's just like the supply is creating its own demand, so to speak. But you can also tell a demand side story that maybe for whatever reason people in those areas that have very high intensity of end-of-life spending, those people actually want to have very intensive end-of-life spending, and so then the supply side is just responding by moving into those areas because that's where all the demand is. So the direction of causality isn't really clear there. But the same holds for preference-sensitive care. So this is basically referring to cases in which there are two valid alternative treatments. So in some cases, like you might have a particular disease, and there will be two ways that can be treated. And it's not, in terms of like the research, it's not clear which way is superior. So you might have a particular type of cancer, and maybe one way to treat it is with surgery, another way to treat it is with chemotherapy, or some combination of the two, or like maybe it's like surgery plus chemotherapy versus surgery plus radiation therapy, or something like that. And so ideally what you would hope would happen in those cases is that basically like the doctor sits down with the patient and then says, look, there's these two possible treatments. One of them does not appear to be uniformly better than the other. Here's like the benefits and the costs of each of these treatments in terms of like side effects and so forth. Which one do you feel is like the one you'd be more comfortable with going forward? And then the patient would make their own informed decision. But in practice, what happens, it looks like, is that if you're in an area where there are a whole bunch of specialists who do like treatment 1 and not so many specialists who do treatment 2, then you end up choosing treatment 1, and vice versa if you're in an area where there's like a whole bunch of specialists who do treatment 2. And so there I think it's harder to tell a demand side story. Like it becomes really unclear to me why